Hi, this is Dr. Carl Goldkamp. If you're interested in learning about the ketogenic diet like I was, to save my own life, then this is probably the podcast for you. 8 years ago, I knew nothing about it. 6 years ago, it saved my life. 3 years ago, I started researching and talking with some of the authorities in the field and attending medical conferences about this to understand why and how keto so dramatically changed my and my wife's Judy's lives. The purpose of this podcast is to share our journey of discoveries with you in understanding how keto is so effective in improving so many different conditions, from obesity, epilepsy, diabetes, infertility, MS, Alzheimer's, heart disease, to name a few. So take a step away from all the hype you've probably heard and roll up your sleeves with me and join me weekly to explore this living miracle that anyone can access. We'll talk science, we'll talk food. We'll explore its history and evolution to today, which is that the sheer wonder of the ketogenic way of eating has changed untold number of lives, unlike anything before it. And in case I forget to mention it, please join our Facebook group, Keto Naturopath. Hi, this is Dr. Goldkamp, and welcome back to another episode of the Keto Naturopath. You're going to be listening to an encore podcast from about a year and a half ago, and it's part two of the protein debate I had with Dr. Cywes, who's a bariatric surgeon. And looking back on this debate, it's a great issue to have as a debate, but I don't think it really was a great debate, and for a number of reasons. I fault myself first for being too polite and not willing to call him out in some of the things he said, but I don't really know him that well. And Doug Reynolds, who's kind of the referee or whatever, the one who came up with the idea, who's the head of, he and his wife started the low carb USA conferences, which are good. And so that's where this came from. How I would say, I think the answer that I feel is that if anybody really wants to know what, and this should have been the answer, is that simply track your glucose and or your ketones, but it's your glucose you're looking at. And right now you can do it with any number of CGMs, and you can do it with cheap CGMs like the Freestyle Libre. And there's even other ones coming out in a more public sector that do supposedly even better, a little more pricier though. And then you can get really expensive CGMs. But anyway, if you track your blood glucose very specifically like that, you'll get your answer. And so I don't believe that it goes. I mean, I've tracked it on a number of people, so I don't believe that it goes up. It goes up temporarily, and then it goes back down to normal. And I've covered that on past podcasts. So valuable information is discussed, but I like when people talk about the experience they've had with their patients as opposed to referring me to a talk that they've attended and therefore got the truth from that talk. It doesn't put me anywhere, it doesn't give me anything more than I had before. So enjoy the conversation, enjoy the debate, and it's a great topic to be aware of. Bye-bye. Hi, this is Dr. Goldkamp, and welcome back to another episode of the Keto Naturopath. And thank you for listening in. So in today's episode, we are going to get to the second half of the debate that I had with Dr. Cywes, who is a bariatric surgeon in West Palm, Florida. Whole different perspective from being a naturopathic doctor. But we overlap in a lot that we talk about, and certainly a lot of our interests in low carb, ketogenic diet and all the results that will change. I really appreciate his mindfulness about how he goes about what he does. And he's been on a number of other podcasts, and perhaps I should get him on this one as well. But this is a discussion that we have to split hairs over a particular point. And that point is, when you as a person eat protein, does that increase your blood sugar? Period. That's it. And the point of disagreement came from the last conference we were in. He said while he was at the conference, while he was standing in line asking a question, that, protein goes to sugar. Well, it's a conditional situation. And so I disagreed with that. So we picked it up in great fashion through the wisdom of Doug Reynolds to put this together. So what I wanted to do a little prequel about is some things that I want to elaborate, because it's fun to have a discussion, but often it goes so quickly you can't really put in the details. And if you talk like me, often you don't even complete your sentences. So I thought it was fair to to enunciate and to complete my sentences and to paint a fuller picture so you understand some of the references that I was making. And one is, see, I have an analogy to people who attempt the low carb, high fat, ketogenic lifestyle and do not succeed. We tend to speak in glowing terms that everybody does well, and look at all the successes, and look at all the interesting things that it changes, and we should all be doing this, and that conventional medicine is totally has its head up its butt. And the last part's true. The other are, I think, are overly simplistic, and there are a number of difficulties that people need to be helped with in order to have whatever they're doing for their ketogenic diet be much more effective. So my analogy for this is that I own a big parking lot, and this is pretend, of course. And for the last couple of months, I've allowed people to park there willy-nilly. And then I realized that, I don't want to do that anymore. So I tell everybody who's parking there, who let me know they're going to be parking in that parking lot, that 9 o'clock tomorrow morning, everybody has to be out of here. It's the end of the free time and we got to move on. So just take your car, drive out of the parking lot, get on the road and go. Okay. Pretty straightforward, pretty simple instructions, don't you think? Well, I show up that 9 o'clock tomorrow morning and I find that half the cars are still there. I'm kind of furious because I'm a little taken advantage of. So I walk up to the first car and I realize actually the drivers are still in the cars. And I walk up to the first car kind of in disbelief and really not understanding why they couldn't just leave the parking lot and go like everybody else. Well, as he rolls down his windows, I realize that he has a flat tire. That needs attending to. And then I look over at other people and I realize, wow, there's steam coming out from under the hood. Obviously, they need some looking at what's under their hood and fix that first so they can take the car out of the parking lot. Somebody else may have a huge pothole they can't get out of. They need help getting out of that pothole. So that's my analogy of what I believe I do here in helping people fill in the pothole, fix the flat tire, look under the hood so they can get out of the parking lot and get on to the straight and narrow of the low carb diet, which I think is the default norm, actually. I think that is how we ancestrally lived for a long period of time. And what has been contrived is the last 50 years for sure, if not the last 100, but certainly the last 50 to 70 years since post-World War II, the industrialization of our food supply and all the engineered artificial ingredients that are put in there and the decrease of nutrition. So that's where I'm coming from and all that. So I bring that up in the discussion with Dr. Cywes, and I thought I needed to elaborate on it. We also talk about the relevance of fat and how that, if people are looking at the ketogenic lifestyle, they do need fat. It is something. Protein and fat, I think, can sustain you forever, providing, when I say protein and fat, I mean whole food sources of protein, which would be steak, fish, poultry, well, all animal sources, not just steak. So it could be lamb, it could be pork, it could be all of that. And so they come with their own fat supply. So in that ancestral way of looking at it, that's quite adequate. Coming from a guy who was deep into a huge vegetable garden annually and grew up as a conscripted child, the youngest of 6, to work forever in our family vegetable garden. I no longer feel that one has to consume vegetables. And if they do consume vegetables on the low-carb diet, it should be green leafy vegetables for the most part, okay? And I do want to thank Dr. Cywes for being such a gentleman in this discussion we have together. He is over the top, polite, respectful, humble, and tremendously deep on his experience and what he has from his patients, bariatric patients. So those are the things I want to mention before we got going, and I hope you enjoy this episode. Take care. And that's how I look at the ketogenic diet. But so what are the easy things? The low-hanging fruit are for deficiencies. Low-hanging fruit
Don't use the word fruit.
Low-hanging.
Sorry.
Aesop's fable. Aesop's fable. Anyway, so those particular things, are the things that
now I got to buy in. I'll say, you know, it's not that tough, and I understand why it's problematic, but look at this. Look what we found. I bet if we took care of this, this, and this, small baby steps, you might say, but really effective, the bang I get out of that buck, meaning the satisfaction and the effectiveness of taking care of the small things now starts to be able to crank the bigger things of, yeah, I'll start looking at the macros, which we can, you know, you can go onto some app like Chronometer or something for babies, for training wheels to get them started. You know, and I do have you know, they need to get a food scale out and find out how much, quote unquote, protein is in a 8-ounce ribeye. You know, some basic eating tools that they don't have. I think the idea, and I think where we are is this generation, or maybe a generation before, is this induced nutritional deficiency, A, by the kind of food we've been eating, and then B, by the medications that we've been on unnecessarily or on too long. And so it's like, that's a mess. So that's the mess I see that is the 50% of the people that really can't make a decent start. They feel terrible. You know, they're depressed, more than depressed. They might, you know, and we know after Dr. Palmer, a couple of talks, that, you know, the mental disorders because of choline deficiency, mental disorders because of carbs, you know, high glycemia, it's like, we can pull that back. And suddenly we find this person underneath is like, we can now do something a little more constructive. But that's what it takes. And I think to sort of dismiss, and that's kind of perhaps what the original statement was, now that we've agreed on this, that it said, you know, there's some work to do, small work to do before we get into the bigger thing. You know, we can make this, I don't know about 100%, Doug, but we can get it up into the 90s.
Yeah, well, that was what I was about to say. You know, I mean, when you say lack of adherence, and I mean, I even stepped.
That was Steve Finney, by the way.
Well, yeah, well, I remember I stepped up to the mic in San Diego and said, why is it only 50%? You know, he was really proud of this 50% that Werther was achieving. And I said, well, why is it?
Right.
Yes, it's huge, but why is it not bigger? And so lack of adherence is a very simplistic term.
Absolutely.
And I think what you're saying is that, and I'll go back and defend Eric Westman a little bit, yeah, because what he says is this works if you do it right. But some people, it's not just that they just don't adhere to the thing. They trying as best they can, but they can't. And he's done talks at some of our events where he actually shows a lot of his clinical data and shows where he works through with these patients that weren't having success, and then found out what it was that was causing their problems, and you fix that, and then they start responding.
So the question is that, and that is different for different people. One is simply, you could say support. Hey, right. You didn't quite understand. I'm going to cobble you a little more. Those are the easy ones. You know, their car kind of worked and they can just get them out of the parking lot. But others, it's a little more difficult, you know, and you got to go a little deeper because, you know, they're in a place that's almost unreachable. They came to you because it wasn't so much the last hope. It sounded easy enough that it could transform their life. It still is, but you got to look a little deeper. And so when you get into certain deficiencies, you know, especially a lot of these things lead to depression. You know, a lot of these, you know, induced nutritional deficiencies is just
starts with depression, Carl. It starts with depression. It ends with carbohydrate addiction. It doesn't start with, you don't drink excessively and then become depressed. You're depressed and then you drink excessively.
Yeah, very good, very good. And also, I mean, it takes looking at, I mean, heck, where people are all in a different context and it has to be recognized. It's like, you know, what are those obvious stressors? You know, speaking of the addiction model, which I love to look at, especially for carb, and I appreciate your whole theme of this, is that, you know, it's like people can take some stress, but when it gets to be too much, and you speak about kids, you know, when they, even when you think of Nora Volkoff, who's the head of the National Drug and Addiction Agency, is that said, you know, they can do so far. When they get to 5 known stressors, that's it. They're highly addicted, highly vulnerable to addiction, be it carbs, be it whatever their friends are smoking, you know, it's going to go. But so that context of what is their addictions, the the post-traumatic stress disorder of the vets, they come back. One of their things is social isolation. You know, and that's a real torture. It's kind of the torture they use on other prisoners. And so recognizing that and sort of having to take care of that as well. So it ends up being a bigger picture. It's all treatable, I think, but it's very exciting, but it leads you into these other things. I say it's the 50% of the cars still in my parking lot, and how am I going to take care of them? And they are now subdivided.
Right. And so there's a bunch of roadblocks preventing those cars from getting out of the lot in time. And it's the same with those 50% people that are not responding, is that I feel like if we can identify what that issue is or set of issues are that are preventing them from responding, then they will. And right. I seriously feel like if we really paid attention to trying to identify and remove those roadblocks, that those numbers would be up in the 90s. And the only reason it would be 90s and not 100 is that there's 10% that we couldn't find the reason that was blocking them. That's and true. That if we could, there would be 100. That's how I feel about this.
Absolutely. I'm with you 100%. And we do have that, back to the Dr. Katz comment, 100% agreement there too. It's fake information that's out there that, from these supposed erudite people, well-educated and credentialed, and it just irks me to no end. It's wrong. It's on the face of it, dishonest. It's not misinformed. It's dishonest. The information's out there. And if I was a researcher, they would know this. And so there's just that. It's always going to be in our face. But our numbers are growing. And the theme of this conversation, and also from Adele and her work, was, words matter. So we get a little more specific in what we agree on and don't agree on. There is a lot of keto mythology out there. And I think we're going to nail it down one little piece at a time. I mean, we're not on Mars, and it's not mysterious. It's just documenting and moving on and saying, there you go. This can be fixed.
I think there are two major issues for me in terms of what we're talking about here. The first thing is, and this is such an important preamble for me. I absolutely love what Verta Health is doing. I think the science, the program, everything else is wonderful. So what I'm going to say next is not a criticism or indictment. Verta Health is the first group of people that have taken this to the people and done great. But Verta Health is a little bit like selling pea protein burgers, vegan burgers, okay? And what I mean by that is that if you look at why does 100% of people not just sustain Verta Health? The first reason is there's going to be a subgroup, a small group of people who are vegans who are always going to go into McDonald's and preferentially order a vegan burger, an Impossible Burger. Then there's going to be a group of people who walk in there who, because of the marketing, because of the advertising, because of that movie Game Changers, they're going to, let me try this. And they're going to try it, and they may like it, they may not like it, and they may eat it for a while, as long as there's marketing and there's salesmanship. And one of the things that Verta does very well is about coaching, but you've got to pay for the coaching. And as long as you've got that access to that coach, it's a little bit like an alcoholic going to AA. You're going to sustain things for the most part because you got the coaching. If Verta just had a plan and there was no coaching, far fewer people would do that. If Impossible Burgers were sold at McDonald's and there was not this billion-dollar advertising to tell people all the time that Impossible Burgers are the same as meat, nobody would preferentially eat an Impossible Burger. And that's the challenge that we're up to that extent. But here's the mistake that we're making. To blame people for not sustaining the eating plan, the ketogenic eating plan, is ludicrous. What we have to do is to figure out why they're not sustaining it. And there are two primary reasons, to my mind, a single primary reason why people are not sustaining it is because of the word diet. Why do you think people, let's take two groups of people. Let's take one group of people who take on a ketogenic diet. Why do people go on a ketogenic diet? The majority of people go on a ketogenic diet to lose weight or to deal with their diabetes. The reason most people try a vegan diet is not because they're trying to eat healthier or because they think it's a way to lose weight. Some people do. The majority of people that go vegan, it's because they care about the planet in a misguided way or they care about animal rights. And they are empowered by this arrogance that they will not eat meat because of poor little Bambi. So they're willing to tolerate the austerity of not eating meat because of their intense belief in the structure when in the climate or in animals. So when you offer a vegan a steak, their primary statement is, how the hell can you kill Bambi? That's terrible, you bad person. There's an arrogance to that. When you offer a new ketogenic person a bit of ice cream, oh, I'm not allowed to have that. It's a very deprivational answer. And all you need is deprivation and a little bit of emotional distress, and boom, they're weak, that boundary is gone, and they fail. So all diets fail. 98% of diets fail, whether it's intermittent fasting, whether it's keto, whatever it is, and it's because of the word diet. Diet is intentionally deprivational. And what you don't do is you're not replacing both sides of the deprivation equation. What diets do, ketogenic diet tells everybody what they should do to replace carbohydrates from a nutritional perspective, with fat on the carnivore diet, whatever it may be. But they completely, there's not a single diet out there that even Noom or whatever it is, although they spout this out, it's absolute garbage. But what they don't understand is that if you step back and you say, okay, carbohydrates are not food, they become entangled in our food system, and they may have historically been part of human survival, part of the food system, just like heroin is part of, or opioids are part of our pain system. We need we have opioid receptors for a reason, but heroin addiction is completely different. What's happened in the modern era is that we are using sugar and starch as an emotion management system, as a dysfunctional emotion management system. And when you rapidly withdraw those and you do not replace them, it's a little bit like getting an alcoholic to quit drinking without having a new standard. So the relapse is not because of the diet, or it is because it's a diet, it's deprivational. It is because there's no form of emotion management replacement. And I think more and more we have to look at a ketogenic diet or ketosis. We've got to look at the deprivation of sugar from the mental health side. And the last thing I'll say on this, the last comment I'm going to make on this is that carbohydrates are unique in the addiction world in that they leave two deficits, a food deficit as well as an emotion management deficit. All other addictive substances and addictive behaviors are one-to-one. It's the removal of the drug and replacement from the emotion management. But the key thing about carbohydrates is most people become abusive of carbohydrates before they're a year old. Before they even know that they're human, before they are a year old, most kids are exposed to chronic, excessive carbohydrates, whether it is because very, very few women wean their children at 4 months or 6 months onto meat. They wean them onto fruits and onto these slimy little bottles of pure sugar, or they formula feeding their babies on baby milkshakes. So even though breast milk is healthy, the weaning formulas are high in sugar and low in fat. So we connect those babies, possibly even in utero, to sugar. You only start smoking at the earliest, at 8 to 10, most people 12 and older. Very few people start vaping before middle school. There are some, but almost every child in America is sugar tolerant, sugar abusive before they're a year old. And that's a huge threat to our society. But why the hell should I develop an effort-based emotion management system if I've got immediate solace from this highly ubiquitously available, highly addictive substance called carbohydrates? One of the keys along that line, and I know I said I was going to stop here, but is that drugs give you instant gratification, instant reward for a price to be paid on the back end.
Absolutely.
Anything that is part of a healthy emotion management system requires effort. You do the spend up front for the reward on the back end, whether that's going for a walk, whether it's singing, whether it's praying. You put the effort in and there's a return on that investment on the back end.
So, Rob, what you're talking about is deferred gratification. They learn deferred gratification. They learn
exactly
support.
Right.
So
right.
If looking back, it's the support that needs to be around that child, or if we're learning a new pattern, but it's deferred gratification. And then you can go right to the dopamine. There was high and now it's low. In what I've learned in the last couple of months is that, so on the low side of dopamine, which you can actually measure, and so it sort of speaks to a history of a higher dopamine, there was something out there that was triggering, and you can find that out in the history if you're just starting from the blood work, is that it disconnects the frontal, low dopamine is low connection to the frontal lobe, the prefrontal cortex, where behavior control comes from, where reflection comes from. So this lack of, it perpetuates itself into just the opposite of deferred gratification, immediate gratification. So having to back away, learn, and do some hard work, as you say. I mean, there's some hard work in life. It used to be called discipline, but we don't do that word anymore. It's just is. And you have to do a kind of a boot camp approach. But one of the features that I think you're talking about, I like the idea that you're talking about emotional management control, is the fact it's better if there's a group of people as opposed to a one-on-one. So the difference of seeing a patient across the desk as one-on-one, they're siloed. They're just, we have this conversation. It might be good. It might be influential, but it's just one. They don't really see where they are other than they see other people out in the waiting room. When they come in, and you can do this online, certainly with 4 or 5, and they get to know each other in the cloister of privacy and look at each other's labs and see the similarity that maybe they're probably all overweight, they're kind of relieved, but also they learned a lot from looking at other people's blood work, of other people's stories. So it doesn't have to be 12 or 14 or 100. That speaks to a different sort of model, but more than one is very beneficial. Learning from others is really reversely transferable in a funny way. So that tribe aspect, however small, is just what a waste.
Human connection is what you're talking about.
Right.
Yes. But
absolutely.
Carl, can I talk? If you don't mind, I'd like to switch to something completely different, which I think is a critical. But this is a critical part. If we circle back to the protein side, and a guy called Dan Quable up in Canada who has just done great things up there, and I shout out to him. And he's just a fat guy who's really found a way to change. He brought this up to me, and I think it happened with me as well, is one of the issues I have with a ketogenic diet, and he's quite right. My whole mantra is we don't talk about calories, because once you go back to eating fat, there's enough processes in the human body to control how much we eat. But one of the issues I have with a ketogenic diet is the difference between a fat-fortified meal, which is your ribeye steak, protein with fat that God or nature made, and the degree to which some people, when they're discussing ketogenic diets, give complete free access. In fact, encourage people to consume massive amounts of fat. And the distinction that I make is between fat fortification, which is a natural amount of fat in the food that we eat, and fat overloading, which is putting bunches of oil in coffee and adding globs of butter to your food. Ultimately, and this is just such a dichotomy for me, especially for the weight loss community, ultimately it is about calories. And even though fat gives us satiety, if you eat very quickly, you can consume an extraordinary amount of fat at 9 calories per gram before you recognize those signals. So Dan said to me, we had this kind of discussion, just like we're having with the protein, about, he said, no, calories should count. And he's absolutely right. You shouldn't count calories, but you need an awareness of caloric load when you fat overload food. And I think the ketogenic diet is very difficult to monetize. And a lot of the people that are monetizing the ketogenic diet are doing so by adding fat to the food that we should be eating. And I've got to be delicate about this, but I don't. We've just got to be super careful about fat overloading. Now, if you're an awesome twin, yes, eat as much as you can because you don't have any to give. But certainly if you're trying to lose weight, eat your fat, but your percentages should be good. I don't know what your thoughts are on that, Carl.
No, I think that, you sort of step back into processed foods, once you start contriving things by putting things on top. I guess the butter is not processed, but what I've seen in terms of experience now is that I think for the first month, first month or 6 weeks, when people start, they really have to be conscious of having their fat. And so when they're coming from, let's say they're coming from the SAD diet, Standard American Diet, they're going to go, I really got to eat all that fat? This doesn't make sense. I go, trust me. So for 6 weeks, I go, we got to box your metabolism in to have the shift. After that, your fat need is going to disappear. You're going to just have satiation with the ribeye. We're using that as an excuse, whatever. And that's going to come naturally. So these fat bombs talk about an errant, what do you call that, industry. It's unfortunate. But saying, that's such a basic lesson to get them to like fat again. So we're going to go fill the fat. If you want to use Ben's slide on that, get the fat in there. After that, there's going to be a natural homeostasis that sort of just disappears. And they go, gosh, I haven't added, oil or butter on my meat in the longest time. And that's actually a minor thing. I think it's the biggest offender is the fat coffees. They go,
yeah, we're not drinking. We shouldn't be. Then it turns into a meal. You turn your coffee into a meal. So I think we just have to be cognizant of that. And I think you and I are on the same page there. But it's interesting that I take care of a lot of patients who do extraordinarily well and they stall out. And often the stall is because they're still fat overloading their food. And for a while, their bodies can compensate when they're enormous. But once they've lost a lot of weight, there's a very delicate balance, and you really have to shift that balance on the caloric load. So I don't like to count calories at all, but I want people to be aware of how much fat they're actually adding to their food. Frying some eggs in butter is fine, but don't add a slab of butter to that egg. And I think I've personally been guilty of that myself, is that I've given as a fat guy, we always want that visceral effect of eating as important as the the placebo effect as the sugar itself. And sometimes we give ourselves an allowance that, fat's fine. Now, biologically, it's okay, but if my metric is the scale, that's problematic. Right. And I think that's an important consideration. And I know that, Doug, you're probably going to release this, and I just wanted people to know that, because that's something we haven't talked about around very much. And I think it's
very important. And you talk in some of our previous talks, you talk about eating sequentially, where I always used to think, okay, people that have their epistat is just broken. It's been broken for 50 years or whatever. Now they want to change, and it maybe takes time to heal, and that's why they're not able to recognize those signals of satiety. Mm-hmm. But the more I listen to you, the more I still think it's possible that some people's are broken, but most of the time, it's really just that they're eating too fast. And that because it takes a while, I think you mentioned something like 20 minutes or something for those signals to start reaching the brain. So eating the way you describe, I mean, it takes a lot of effort and discipline or whatever to do it like that. But if you just, which is putting a big plate in the middle of the table and then dishing yourself up small portions onto a side plate, eating that and then deciding, am I still hungry? Because that takes time. And I think if people don't have the self-discipline to go through that whole rigmarole, as long as they do what you say and be aware of the fact that they need to be cognizant of how much they are eating, because in the end it does count. And so slow down, eat slowly, eat slower, like I do sometimes. I leave a bunch of stuff on my plate until it goes cold because I'm talking too much. Yeah. But in that way, it's like I look down and think, shit, am I really still hungry? Do I really need to finish what's on this plate?
I think there's a couple of things. I think when you're coming away from carb-centric standard American diet, you do have this sort of immediate, you still have that part that's immediate gratification that goes to food. And when you start to change over that, you're changing that behavior, but more than you're changing that behavior, you're reconnecting to that part of the brain. I mean, there really was, I think I would call it a pathology that they had that you're changing, and gradually you're getting a more thoughtfulness. So if they're thoughtful, and we call it meditative, about what they're eating, then that's really, they're bringing in the front of their brain, and that's a big deal. So it's less about being spontaneously scarf and no, have smaller. And so that's a thoughtful plan. It's a deferred gratification. It's a learned thing to have. Having said that, I will say, when I've gone to your conferences, that you do have enough fish, meat, and chicken, I go, that's all I have. And for lunch, I just have 2 meat sticks up in my room with a cup of coffee. We do put a little collagen in, and I put a little C8, and I am good. And every time I've come back, those are the only conferences, when I come back, I've leaned up in the 3 days I've been away. I go, so why don't I eat this way at home, which I thought I did mostly, but it's a part of, I'm totally satisfied. I great conversations at dinner, of course, but you eat enough, you talk, and it's done. And but I think at the beginner's role, that beginner's mind, almost like a Buddhist orientation, is that they need to have portions and they need to have sequence is certainly part of it. But what they're really talking about is the mental reconnection. I mean, all this is just exterior to create that interior change, specifically dopamine to the prefrontal cortex. But it's really interesting, however you look at it, it's serving the same purpose in the end.
Yeah, and
sorry, just to recap on your point, the word I use is that human beings are trained to eat preemptively, because there is no feedback control when you eat carbohydrates, because carbohydrates aren't essential to human survival, we have to have a mathematical formula about how much it's okay to eat. And that's called a portion, and it's based on calories. So human beings, when they're hungry, they decide in their heads how much they think they need. It's called preemptive eating. And then they put that food on their plate and they start to eat it and they finish it. And very often that's overeating, particularly when there's carbohydrates there. And the parallel to that is how stupid, and I use that word in a very quiet, careful, how dumb it is to manage diabetics preemptively. And that's how endocrinologists, the entire management of diabetics by most endocrinologists is preemptive management. They tell them, eat this amount of carbohydrates, and then they've got these tables that they look up to see how much insulin they have to give themselves preemptively based upon the carbohydrates they're going to eat. That is ludicrous. The right way to do it, as Doug said with eating sequentially, is eat until the signals from your body tell you, I'm full, and then stop eating. And the way you do that is to put the food in the middle of the table and go back and forth, and it slows you down. The way to treat a diabetic is, first of all, without a carbohydrate load, but secondly, let them check their blood sugar. Let them look at the CGM. And if the CGM starts to go up, put yourself on a sliding scale where you're dosing according to your CGM, not dosing preemptively based on what you're going to eat. And that's the way you avoid, because every diabetic's petrified of lows. Well, if you overdose insulin, if you screw up your calculation, or you don't get all that food in, or there's something with your gut, or you throw up, you're screwed. Whereas if you dose according to the CGM, you're in great shape because you give yourself just enough on a sliding scale to manage your blood sugar. Exactly the same way when it comes to eating. When you start to feel full from eating fat and you stop eating, irrespective of whether it's 6 ounces of your steak or 20 ounces, that's not preemptive eating, that's feedback eating. And you're listening to the signals from your body that says, I've had enough, rather than I think I should have this amount.
Yeah, and so I was just going to chip in something random there, was just because a shout out for the Boca Raton Marriott chef, because Carl brought up the meals and the dinners, and he just did such a fantastic job there that people could just go and dish whatever they wanted and never be concerned about what was in it or whether it was keto or whatever. So
no, it was tremendous. It was tremendous. So to speak the way things are, when you line up and we have the panel, when it's about 2 hours and you bring in the questions, it comes to that sort of camaraderie. It's a great closure because you're intimate with the people you've learned who are left and right and front and back and all these different people. And now you're sharing each other's questions. And so there's a dynamic there that is very helpful to learning. You learn from, I didn't think of that question. I didn't think of that question. So it might be me and it's kind of like the 1 patient versus 4 patients. It's amazing. You have a multiple, which is geometric, not linear in terms of. And I think it's,
I'm constantly thinking about how I can do things better, but so far that panel has always been a really popular thing and it's worked out well. And the thing I think we've got to look at it is that, okay, it's the same as people come up and I make these rules about Q&A, right? And they have to ask, if it requires a backstory in order to ask this question, this is not the right place to ask that question. You need to ask that question of the speaker at dinner, where or come to me and say, I have this question, and if it's a really big question, then I'll get you guys on a podcast and ask a question and have an hour to answer it.
Agreed. It's just the arbitrary enforcement, Doug.
The only problem with that concept, Doug, is then you get some idiot coming up there and saying protein turns to sugar.
Exactly, and then you're screwed, right?
Then you're screwed, yeah.
Yeah, and you're stuck with a podcast or whatever this is.
Yeah, exactly. Yeah. So what we've just done today is the backstory.
Yeah, right. Yeah, that's where you are.
But that was the whole point: is that wasn't the right environment to continue that conversation, but it needed to be continued, and so we've had it here. And it's always dangerous to pitch people against each other who have differences of opinion. But I kind of felt like you two guys had enough, were respectful enough that this would work out. I even always still said, look, I'm going to record it and we'll see what happens, right? If it turns out well, I'll publish it. If it doesn't, I won't. So you still never know, but I'm really glad it turned out this way. I feel like it was hugely valuable. It's going to be a great episode, and I really appreciate you guys agreeing to do it. It was awesome.
Absolutely.
No, there's a lot of clarity. I think that's the key thing, is that it helps to clarify things. And, I said we're all on the same page. One comment about that, Doug, though, is what was so cool about talking about this is how under different circumstances the body behaves. And especially how the hormonal interrelationships change depending on different circumstances, type 1, type 2, insulin resistant, athletes. And I think as people that give guidance, we have to be cognizant of every one of those arenas. And we really have to be empathetic to what the needs of our people are, rather than of the person sitting in front of you, rather than being the white coat expert telling people what they have to do. And that's more and more what I've realized in my own practice, is that to tell someone what they should do versus finding out what someone is capable of doing is so important, because so many people tell the diabetics, here, you've got to check your blood sugar 4 times a day, you've got to eat this. Less than 25% of diabetics in my office ever check their blood sugar, despite the fact that their doctor has told them so many times to do it. There's a disconnect, and it's a lack of empathy about taking some poor guy who's just found that he's type 2 diabetic. Now he's got to go and stick needles in his finger several times a day. We've got to be able to hold the hands of patients. And I think when we talked about sustainability, a large part of it is how we, Carl, myself, you, how we relate to people and how we convey that message. Stay within what the person is able to do rather than what I think they should do. And that's so difficult.
Yeah, I think that's a critical takeaway from this, and that is so important in everything we do. And then we were just talking about, the whole 50% thing and why people fail, and I think that's the reason, is that not enough.
One commonality, Doug, by the way, of your speakers, and certainly Rob, these are people who ask questions. You know what I mean? There's followers and people who ask questions, and certainly we need to know certain rules, and so we all need to follow to some extent. But I think what really strikes the audience, they really enjoy listening to it, is it's the person who's speaking is really trying to answer their own questions. It's like saying, these are the problems I've been working on. This is what I've been seeing. This is what I think I know. This is what I learned. It's such a delight to hear that kind of presentation. And Rob, you do that a lot. And you come up with your own sort of really nice way of presenting things in that way, that idea, but it's because you're answering your own questions, the way I look at it.
Right. And I learned so much. Like, I've learned so much from this interaction. Not only do I learn facts, but I also learn method, and I learn how I may have been misunderstood by. It's so obvious to me, people don't. So all of those things. This is not just factual learning. It is humanistic learning, and that's what I love about it. I've grown so much as a human being through this process, and the respect I have for the two of you and the humility that we have toward each other makes this such a positive way to grow and to learn. And hopefully people listening to this can witness that as well and put their arguments on. I always tell my patients this: bring your defenses down. I'm going to give you for free a little virtual bag. Put all the information into that bag and take it home with you. And every few hours, dip into that and take another thing out and process it. And in 3 days' time, you'll understand what we talked about. And I'm going to do the same with this discussion. I'm going to process it. And that's going to be such a big deal.
Likewise.
Awesome, guys.
Okay.
Thank you so much.
All right. Thanks, Doug.
Thank you. Thanks, Doug.
Thanks, Rob.
Thank you very much.
Hi, this is Dr. Goldkamp. I just wanted to encourage you to send in your questions to drgoldkamp@ketonaturopath.com. Many of you have, and so what I've done with these questions, that gotten back to most of the people I email, but some of the questions that were so good, and if they were overlapping to other questions, I would combine them and try to put that into the topic of a podcast, either via one of the micro topics that are covered in an interview. As you know, we cover a lot of topics in any given interview, or some of my own sort of reporting, if you will, on some of these issues. So please keep the questions coming. Feel free to send in an email, and I will get back to you. One thing I want to say, a number of questions have come in which I've given this answer and the email didn't work. So just make sure that you're receiving at the same email that you sent it in. And I think that might have been the difficulty. So I look forward to your questions. I just wanted to make sure that you knew that I'm open to answer your questions. And I think this world of keto is not just black and white. You know, it's nice that it's simple, but it's not simple for some. I'm really trying to, go down as any of you who have listened to all my podcasts. We started way back when, history and evolution and epilepsy and so on and so forth. Now we're seeing some tremendous overlap in various mental disorders, such as schizophrenia or neurological disorders that are not just epilepsy. And also, just for people in losing weight, it's sometimes pretty complicated for them to engage in keto. And so they need some help. And so that's the whole point of, at least that's what I think I'm doing, is exploring the world of why are there other factors. And so in exploring some of those other factors, we've covered addiction, we've covered hormones, we've covered nutritional deficiencies, we've covered certain metabolic lab results, and we'll go further. We'll even get to more on genome and aspects. So these are all just contributions that make for an obstacle for some people to engage easily in the ketogenic diet. This is my belief, and these are the things that I've discovered. And I think other people have discovered some of these things, but not ever put them together. So stay listening, send in your questions, and I will definitely get back to you. Hi, this is Dr. Goldkamp again for a brief reminder of something I completely forget to do at the end of every episode. You've heard me talk long enough in many different episodes, but what I would love you to do, and many of you have already done this, I just want to reinforce this particular behavior, which is to send me your questions. Send me your questions on anything you have about keto. If there's something that I don't know, I will look it up. And if it's something that intrigues me, I will probably make an episode, a podcast about that particular topic. So what you need to do is to send me your questions at drgoldkamp@ketonaturopath.com. So that's DRGOLDKAMP at KETONATUROPATH.com. Dr. Goldkamp@ketonaturopath.com. Feel free to join our Facebook group, which is also ketonaturopath.com. That's been growing lately. You also have to answer a questionnaire should you choose to join. And I don't ask for your email. I ask that you follow our terms. I try to avoid advertising and the obvious interruptions of just a good Facebook group. So hope to see you at one place or other. Please send me your questions and look forward to talking to you and getting to know you. Take care.